Hi, to welcome all to this episode of Conceptual Anesthesia. We'll be talking about blood component therapy. Okay, so the idea is to make you aware about what the blood bank does, how we get the different components of the blood, when are they needed. So I will just acclimatize with you the whole process, how do we store the blood, because this can definitely come up as a MCQ or as a short question, and we should actually be all aware about this since we'll be dealing with blood and blood products throughout our life, whether we work in anesthesia or critical care or any medical branch per se. So let us start. So remember in 1900, the ABO blood grouping system was classified by Landsteiner, and the first pre-transfusion cross match was done in 1907 by Ottenberg, and the system of RH typing was invented by Landsteiner Weiner in the year 1940. So remember just the name Landsteiner and Ottenberg. So what is the logic about blood components? What are different blood components? They are packed red blood cells, washed packed red blood cells, leukoreduced ones, FFPs, cryoprecipitate, and apheresis or platelets. And how do you separate the blood products? So it is depend on the specific gravity, or you can say density. So when you let them settle down, they will be differentiating into the different components, the plaque red blood cells, the platelets and leukocytes, and the plasma from below top. And if you want to do that quickly, you have to centrifuge. A whole unit of blood initially is processed by centrifugation to separate red blood cells from platelets and plasma. So red blood cells will be lowest, platelets and leukocytes will be in the middle, and plasma will be in the top. And the separation of whole blood into its cellular components allows each to be processed and stored under optimal conditions, allowing targeted therapeutic deployment. And single component requirements, remember, can be done. So you can take the whole blood and divide into different parts, or you can just take from a donor what we call as apheresis. Like we have platelet apheresis or leukocyte apheresis, you can take a specific component from a specific donor. So preparing only packed red blood cells and FFPs is by a single step, heavy spin centrifugation. However, if you want platelet concentrate and PRBC concentrates, they can be two-step centrifugation. So I'll be talking about this process in a bit of detail. I want all of you to understand this. So firstly, I'll talk about apheresis. That means taking a specific component from a donor and giving back the donor rest of the blood components. So the working principle can either be centrifugation, that is the specific gravity, or filtration, that is dependent on the different size of the blood components. And the most commonly used equipment uses the centrifugation principle and also can give the leukodepleted products. So what happens in this method, fixed quantity of blood is collected in a bolus called as extracorporeal volume. What do we mean by extracorporeal? That means out of the body. And the required component, that is platelets for example, is separated and collected in a collection bag, and other components, so blood removes the platelets, and what are the other components like red blood cells, leukocytes, and plasma, they are returned back to the donor. So whatever you component you want to select, whatever component you want to take it out of the body, you take only that component out of the body. That is what mean by apheresis. Apheresis again is of two types. It can be intermittent or continuous working. So intermittent equipment uses single vein access for both collection and return. You take the blood out of the body, take the components, separate the components, and return the other components to the person or to the donor. And you do it repeatedly till the therapeutic dose is attained. When continuous, you have two simultaneous phlebotomies. So there are two lines. One is for the collection and one is for the return. So collection, centrifugation, and component collection return occur continuously and simultaneously. So if you go to a blood bank to do a platelet apheresis, this is mostly done in continuous working principle. But just for understanding, there are intermittent, which has just one line, and continuous working, which has two lines. So nowadays, continuous, if you want to donate a apheresis, suppose any relative or close one has dengue, God forbid, and you have to transfuse platelet apheresis, that is how you donate through continuous working apheresis technique. So various components, as I told you, can be so different components can be taken through the apheresis, and the rest can be returned to the person. Now this is a centrifugation, if you can see. So this is the other technique. The in this what happens, the whole blood is taken out. You donate the whole blood, and then during centrifugation, different components can be separated. So you do a low centrifugation from the whole blood to separate between the platelet rich plasma which stays on the top and packed red blood cells which is down below. Then packed red blood cells can also be differentiated into frozen red cells which has a longer half life and the leukocyte depleted red blood cells. When you do the heavier spin and you do it for a longer duration of time to the platelet rich plasma, we can separate the platelet rich plasma into platelets and plasma. So platelet rich plasma again has two components, platelets and plasma. So platelets can be separated and what we call as platelet poor plasma, from which we actually can make the fresh frozen plasma by freezing, or we can make the cryoprecipitate. So that is how you separate the different components of the whole blood. And I want to tell you in a bit of detail this technique. So just as an example, if you have four collection bags, the first one on the right or the left is the whole blood, and the third one is the solution, which is a preservative solution. And I'll talk about preservative solutions also in a bit of detail. So what happens? Whole blood with satellite bags are attached is a centrifuge in a light spin. So as I told you, first you do a light spin to separate the packed red blood cells and the platelet rich plasma. So platelet rich plasma is on the top. Here you can see the platelet rich plasma is on the top. It is separated in the second bag, and you this is the additive solution and it is added to the red blood cells. So then red blood cells are separated. So when you separate the red blood cells, you have the platelet rich plasma, the preservative solution, and an empty bag. So platelet rich plasma is again centrifuged and platelet is expressed of the, so you separate the plasma and the platelets. So the platelets are separated, FFP is separated, and you can convert the FFP to a cryoprecipitate solution. So that is how you do a centrifugal solution, and you also add a preservative to separate different components of the blood. So just to give you an idea, whole blood is not now commonly used. Maybe when I was an intern or that was the time whole blood was used. Nowadays, most of the time we use component therapies. But again, if you have a polytrauma patient and you want to replace all the blood components, you can sometimes use a whole blood. But definitely preferred is a component therapy. So just to give an idea, the whole blood, there is no component that is removed. It is infused usually in the 4 hours of issuing, and we do a blood cross matching, which I'll be telling you in detail at the end of the talk probably. And the various shelf life is increased by the various solutions. So I'll be talking about all of these solutions in a bit of detail. Then what is commonly used nowadays, the most common component that we transfuse, it's a red cell concentrate or a packed red blood cells as we commonly call it. So remember, how do you do it? A 450 to 500 ml volume of whole blood is collected from each donor, and assume you have a donor hematocrit of 42%. That means the hemoglobin is around 14 grams per deciliter, which is the normal average range. So 500 ml of blood, just for simplicity, will have 210 ml of red blood cells. So during centrifugation, roughly 90% of both plasma and anticoagulant solution is removed, bringing the hematocrit of the red. So red blood cells can be concentrated, and the hematocrit from the whole blood of 42% is increased to 80 to 90%. And when you add the preservative solution, it dilutes, so lowers the hematocrit around 60 to 70%. And this hematocrit of the red cell concentrate is actually dependent on the donor's hematocrit. So donor has a hematocrit of 42%. That is why we say it's around 60%. Suppose the donor hematocrit is higher, the red blood cell hematocrit will always be higher. So the normal is 60 to 70%. So the final concentration of the red cell concentrate, that we commonly call as RCC, balances a desire to minimize the unit volume against the need to ensure adequate diffusion of nutrients. So idea is to give a minimum possible volume to the patient. We want to increase the oxygen carrying capacity. So why do you want to improve the hemoglobin of the patient? So idea is to improve the oxygen carrying capacity. And as I told you, the actual volume of red blood cells in the unit of blood and the final hemoglobin content is dependent on the characteristics of the donor. So volume of red blood cells can be reduced by up to 15% in units that are filtered to remove the WBC. So preferred nowadays we have washed and irradiated and leukodepleted. I'll be talking about them also. So remember, as I told you, red blood cells can be collected by apheresis also.